Hi everyone, we're back. I'm here to welcome you to another episode of The Heart of the Matter. I'm here with Bourann and Ankit. We had a little bit of a hiatus because we were busy interviewing for fellowship. And as of now, all three of us have matched for fellowship and we're all going to be cardiologists. So we hope to continue to provide fun content like this, and we'll see how it grows and changes with our further training. But without further ado, Baran is going to talk about the trial that we're going to talk about today.
Yes, welcome back, guys. Today we're going to be talking about hypertrophic cardiomyopathy, and the trial is the MAPLE HCM trial, which I'll get into a little bit of in a bit, but I just want to give sort of like an introduction in hypertrophic cardiomyopathy. It's the most common inherited cardiac disease in the world, and it involves mutation in the sarcomere proteins, and then patients develop this asymmetric hypertrophy in the left ventricle. Not everybody with HCM develops obstructive physiology, but a large portion of them do. And then subsequently, because of that obstructive physiology, they develop symptoms like shortness of breath, dizziness, syncope, um, can be very similar to heart failure type symptoms, and they can be, exercise limiting symptoms and affect quality of life. Usually, when we diagnose HCM, it's on the basis of an LV thickness of greater than 15 millimeters. And then there's like some other criteria depending on other history. And, like I said, one of the things patients can develop is this LVOT obstruction, that causes this variety of symptoms that can make patients very uncomfortable. And for a long time, the main way that we managed these symptoms was with beta blockers primarily, and then the non-dihydropyridine calcium channel blockers. And the idea was that if we decrease this hypercontractile state, and we increase the time for LV filling, that we could reduce this LVOT gradient and then improve these obstructive symptoms. But the body of data or the evidence that we use for these things was not necessarily the highest level of evidence. And so if you look at like the 2024 ACC AHA guidelines on hypertrophic cardiomyopathy, these are class one recommendations, but the level of evidence is these non-randomized, primarily observational studies where we think there is a benefit in using beta blockers. So, for example, it's sort of this like stepwise approach, but these are all class one recommendations. And in a patient with obstructive HCM and symptoms attributable to the LVOT obstruction, you start with the non-vasodilating beta blockers. Then, if patients either are not able to tolerate or they're ineffective, you go to the non-dihydropyridine calcium channel blockers. And then only in the like third step of this do we talk about these cardiac myosin inhibitors, which is going to be the basis of this MAPLE HCM, which is a newer class of medications that reduce myocardial hypercontractility. They decrease the number of myosin actin cross bridging in the sarcomere. And we've had some really good studies to show that they're pretty effective, starting with mavacamten. But if you look at the guidelines now, they're really like not first tier for us. They're like a third line agent. And so, because we have some promising, results from other studies and even just like anecdotally from patients, significant improvement in their symptoms, there's sort of a push to see if this can become like a first line agent rather than a third line agent, the way that it is now. And so the MAPLE HCM trial is investigating Aficamten, which is another cardiac myosin inhibitor, versus metoprolol succinate, which, again, like we said, the non-vasodilating beta blockers are the current standard of care. And this is in patients with symptomatic obstructive HCM. And Anisha will talk more about the methods.
Thanks, Baran. So I'm going to talk a little bit about the methods. So the Maple HCM trial was a head-to-head phase 3 international double-blind, double dummy randomized trial. So we were all looking up what a double dummy trial is because we're learning every day. And so what that means is that both groups received a placebo. So one group received Aficamten plus a placebo in place of the metoprolol, and the other group received metoprolol and a placebo in place of the Aficamten. So, the eligible patients were between 18 to 85 years old. They had received a diagnosis of HCM, and this was defined specifically by a left ventricular wall thickness of at least 15 millimeters or greater than or equal to 13 millimeters in the presence of a disease carrying or a disease causing genetic variant or family history of HCM. Sorry. At the screening, patients were required to have an EF of at least 60% and evidence of a resting obstruction or a latent obstruction. So, a resting obstruction is LV outflow tract gradient of greater than 30 millimeters of mercury at rest, or a latent obstruction, which is a left ventricular outflow tract gradient of greater than or equal to 50 millimeters of mercury after Valsalva. So, these patients were required to have symptoms and impaired functional capacity as evidenced by the NYHA classes. So they either had to be class 2 or class 3. They also had the Kansas City Cardiomyopathy Questionnaire summary score as a marker. And so it had to be less than 90, lower than 90. And the scores for this specific questionnaire range from 0 to 100, with lower scores indicating a worse quality of life. So they also additionally, because of, as I'll discuss, the primary endpoint, they had to have an age and sex predicted peak oxygen uptake of less than 100%. The way that they did this was the starting dose of the Aficamten was 5 milligrams, and the starting dose of the metoprolol was 50 milligrams. And at each week, 2, 4, and 6, the dose of the Aficamten was escalated in 5 milligrams, and the dose of the metoprolol was escalated in 50 milligrams. So the total final doses, the maximum doses for both groups were 20 milligrams and 200 milligrams. So this trial of note was a total of 175 people. There was 87 people in the metoprolol group and 88 people in the Aficamten group. I think that we'll discuss more of that in the results and the discussion, but I think that I just wanted to bring it up because I think sometimes these trials sound like they're very large and or they're very small, but I think also in this specific patient population, we have to take account for that. So the primary endpoint for this specific study was the change from the baseline to week 24 in the peak oxygen uptake as assessed during cardiopulmonary exercise testing. And then the secondary endpoints was there was 6 pre-specified endpoints. They were split into 3 groups and then tested hierarchically. An improvement from baseline to week 24 of at least one NYHA functional class. So if they started at 2, they went down to 1. If they started at 3, they went down to 2. And then also a change in the baseline from week 24 for the Kansas City cardiomyopathy quality scale, their NT-proBNP level, their left ventricular outflow tract gradient after the Valsalva, left atrial volume index, or the left ventricular mass index. Those were all the secondary outpoints. And then of note, the safety endpoint was that it included when the EF went less than 50%, because all these people started with EFs of 60%. So that's kind of how the study was structured, who was included, what they were measuring, and now Ankit is going to talk to us about the results.
Alrighty, hey guys. So as Anisha mentioned, this study's kind of nice because the primary and secondary outcomes have like physiological outcomes, echocardiographical outcomes, and then patient-specific outcomes, right? So the primary outcome was again the peak oxygen uptake. So peak oxygen uptake reflects your cardiorespiratory fitness. So the mean change, excuse me, in the peak oxygen uptake improved with Aficamten, went up 1.1 versus actually going down with metoprolol, actually went down 1.2. And now going to the 6 pre-specified secondary outcomes that Anisha mentioned. The first one is the NYHA class level. About 51% of patients on Aficamten improved one NYHA class level as opposed to 26% metoprolol. So it's a pretty large difference. And you'll notice that for the subsequent ones too. The mean increase in the Kansas City quality of life scale went up more with Aficamten, 15.8 versus metoprolol, which is 8.7. The NT-proBNP levels actually were higher in the metoprolol group as compared to the ones on Aficamten, which is kind of interesting. And then going to the echocardiographical outcomes. And this one I think was kind of the main one. The mean decrease in the LVOT gradient after Valsalva maneuver went down 40 milligrams of mercury in the Aficamten group versus only 4 in the metoprolol group. And then a few others. The mean decrease in LA volume, which is often reflective of your LV pressures, went down in the Aficamten group versus actually going up in the metoprolol group. 3.8 going down and 2.8 going up. And then lastly, the LV mass. LV mass was not different between groups, but it actually did trend lower with patients that were on Aficamten. So as Anisha mentioned, there was a recovery period, right? So there was a 4-week washout period, and then the qualities and these secondary outcomes were observed, and the improvement that had been noticed in the primary and secondary outcomes initially were no longer present. So that may reflect some sort of reversibility component, but if you're not taking the medication, it's not permanent. And then some more detailed analysis that we kind of talked about as well. So when they compared some of the vital signs, blood pressure and heart rate, they were higher in the Aficamten group. But when we looked at kind of the baseline people that are included in the study, more patients with hypertension were included in the Aficamten group compared to the other ones. Aficamten was superior in every subgroup analysis that was conducted, but it wasn't necessarily like the same level of effectiveness all throughout. There was some trends to it not being as effective in patients that had a BMI over 30, had higher NT-proBNP levels at baseline, and had more of a chronic obstructive HCM as opposed to one that was recently diagnosed. And then coming to the efficacy and safety, there was one death in the Aficamten group from a brief viral illness, but otherwise was largely well tolerated, and most of the patients actually reached the maximum dosage of the medication. So in summary, Aficamten was superior in all the outcomes that we'd mentioned compared to metoprolol as a monotherapy. So now, with all this in mind, now we're going to kind of open up the platform for the discussion. So what do you guys think? What are your thoughts, and how does this change our practice?
I mean, I want to come back to, I think the thing that really sticks out, especially after the results, is like what Bourann mentioned in the introduction about how we use metoprolol, right?
Yeah.
How we had these observational studies that then became expert consensus, and then that's been the standard of care that we've been so diligently using, whether that's in our cardiology clinics. When we're doing subspecialty clinic right now, and as we will continue in our careers, or even just inpatient, right? When we newly diagnose somebody, we make sure that they get on their, get on a beta blocker, metoprolol. But to see how drastically the aficamten is so different, and really, actually, if you look at the results and based on what you shared, that the metoprolol actually doesn't really improve much. I think that actually feels really dramatic to me too. That even if is it improving people's quality of life that much? Is it improving their symptoms that much? Is it doing kind of anything? Of course, what we don't have in this trial is a placebo group, which has a control group, which has, obviously with where people are taking none of these medications, whether that's ethical or not is obviously the question here. But also my question is, I want to see how metoprolol even just compares to nothing. Because if we're seeing that metoprolol actually doesn't really improve quality as much as we thought it does, even if it improves metrics, specific metrics, or Ankit, I know you were about to mention something about the vitals. Go
Yeah, yeah. So what's interesting, with Torpol, as we know how it works, right? And it does make some changes to the more largely to the heart rate as opposed to the blood pressure. But with those changes even in mind, there was not that much of a change in the gradient, which is kind of
Mhm.
interesting. So maybe not the physiology isn't completely correlated well. But yeah.
Yeah, agreed. I think this is like it makes sense from a physiology standpoint that, decreasing contractility would help with your LVOT gradient and that you should then theoretically have an improvement in symptoms. And I mean, in the same vein, that's what mavacamten or avacamten do. It's just a different mechanism by which they do it. And so maybe that's what really matters. It's not, the proposed physiology, but the way in which alter the physiology. So, and the other thing that, we talked about before we filmed this is that metoprolol and the other beta blockers um, as side effects can cause a lot of the same symptoms that patients who have symptoms from their obstructive HCM have. And so how do you delineate what is a result of the HCM and what is a medication side effect. And if it's that common, then is this even an effective therapy if you are just, whether you're altering the physiology or not, if the symptoms come regardless, then the point of this is all symptom based, right? We're not here investigating mortality, or morbidity. This is just symptom based, functional capacity, quality of life metrics. So, if that's not our end goal, then I feel like, that's an important consideration is toleration of medications and if their actual quality of life benefit is there. And for these myosin inhibitors, they really don't have like, at least so far, this isn't the biggest sample size. Um, they don't have like a lot of adverse side effects, particularly Aficamten. I think in some of the studies with mavacamten, they do have some, instances where there may be some association with AFib and, things like that. But at least in this case, they really didn't see anything like that. So it seems like this is probably safer, better tolerated option than the metoprolol.
Just to
And
note,
those,
I know, Bourann, you were saying that that we don't necessarily have mortality and morbidity effects, which we don't have anything right now. But the thing about the aficamten that was shown is that it consistently reduced the NT-proBNP level, which, I think in the future we will see that this actually does decrease the future adverse outcomes that are related to HCM. So there is something that could be there, even on that note. But again, focusing on the fact that after a 4 week washout period, there was nothing, there was no impact left, right? That these patients had to continue to take the medication to have the improved quality of life and the improve in their NYHA class.
Mhm.
So what are we like, what's our, yeah, like you said, what's our goal here? Like just wanted to, add those two things in to kind of echo your sentiment.
The good
yeah,
news is, because of this study, the FDA did approve Aficamten for patients with symptomatic obstructive HCM. So it will be more widely available. We'll definitely have a larger population of patients to observe the effects of it. And maybe it will, as you can see, this stuff is practice changing, which is why it's so cool that, that
yeah.
these studies actually impact the way that we practice medicine. And the hope is that through these studies that the guidelines will change and then it will be like the top of this, stepwise approach to start with the myosin inhibitor, because that's also informs how insurance companies, cover or don't cover certain medications. And so it's like this, trickle effect, which is cool to see.
Yeah. And then one last thing I noticed, just like the demographic of people that were included in the study, it was kind of, I feel like in Detroit, we have a large African American population, and a lot of them, I think, more drastically than others, present with a lot of this physiology, and we see that firsthand. But there was only like one black person that was included in the study, which is kind of interesting. Doesn't may not necessarily reflect the North American landscape. But yeah, I think that was interesting. And then the only other thing, as Bruno was saying, there's like no crazy like CYP interactions that Aficamten has too. But yeah, I think that's pretty much all I had to add.
Yeah. I mean, I think the only thing right now is that mavacamten is cost prohibitive. So,
Yeah,
and most of our patients that insurance won't cover it, and most of our patients can't afford it. I mean,
yeah,
I don't think any regular, even reasonable, like any person in any, I would say even upper middle class, socioeconomic can afford it's the medication. It's thousands of dollars per month. And so hopefully having these studies proving that they are better than the medicines that we are using that are cheap, and showing that this can actually improve people's quality of lives, will continue to encourage us to use them and also for insurance companies to approve them so that we can continue to take care of our patients the best way that we possibly can.
oh yeah. And then the last thing, I don't remember if we touched on this, but the adverse effect profile with them were basically similar between Aficamten and Metoprolol. Like,
Mm.
Mhm.
yeah, more or less.
Yeah. So,
So yeah,
I mean, I think
very good.
it's exciting. I mean, that's what we say every time. We love what we do. We love what we're planning on doing. And I think that to see it change, I think that's the biggest thing that we definitely that we even discuss with our attendings and with everyone is like, oh, 10 years ago we were prescribing warfarin and now Eliquis is the standard of care,
Yeah.
or all of those big the changes that are very normal to us, but feel in 10 years, where will we, when we're attendings and we're, working with students and residents and saying, oh, okay, like, yeah, when we were there, Aficamten was, wasn't even, just got approved. It wasn't even on the market, but
Yeah,
yeah. Okay. So my question, which it has been some time, is what are you looking forward to most about fellowship? It's just a sweet one. I'm gonna make Ankit start today.
me. Um, excited to learn, I think. I know we were talking about this earlier. Cardiology is very thought-provoking. It's also a lot of stuff that you have to learn. So I don't think we'll be masters of it at the end, but I think it's cool to learn every day.
Mhm.
Yeah.
Bron.
I think I have the same answer, honestly. I mean, this is what we were talking about before, is
Copy.
that like, you only begin to realize how much more there is to cardiology once you start to kind of like actually peek in. It's like, I mean, what we think encompasses cardiology is what cardiology is from an internal medicine perspective. But when you actually dive in, there's so much more. I mean, like, not even just the meta, it's like echo is its own world of like physics and, all of that stuff. And we have like just this like limited view of it right now. So I think it'll be fun to actually like have a grasp of all of those things that you just have this like very surface level understanding of.
Yeah, for sure. I mean, of course, I agree with both of you. All of us love learning, which is why we're here on this podcast
Yeah.
and investigating different studies and stuff. And I also think just learning new skills, I think that's at some point at the end of your internal medicine training, we learn, but you obviously you're always growing and moving and trying to learn and read new things and new standards of care. But of course, you end up, the growing and learning and the new skills kind of slows down towards the end of your training. And I think it's going to be very humbling, no doubt, of how many new skills and new things that we will learn, and it will be trial by fire. But I think just being able to continue in that endeavor and just have a fresh perspective that's kind of new and a new endeavor, I guess, is what I'm most excited about.
I'm also excited to move. Let's say that.
Ankit's ready for
Ankit,
only warm weather.
I know
yeah.
this. Not meant for this.
Which has been referenced in previous episodes as how much Ankit hates winter.
Yes, and he got his wish. He
He
will be
got his
moving.
wish to move to Florida. So,
Thank God.
but yeah, thanks everybody. We're glad to be back, and we will be. And we might have some other different faces, different friends to kind of continue in this journey of learning and sharing. So we'll see you next time. Thank you.
Bye, guys.
Peace.
Bye, everyone.